SmithKline & French Laboratories is pleased to bring you the second in a new audio cassette series, Update on Borderline and Narcissistic Disorders, highlights of the 8th Annual Winter Psychiatry Conference of the Menninger Foundation. Dr. Marsha Linehan, Associate Professor of Psychology at the University of Washington, opens the program with a discussion of dialectical behavior therapy with borderlines. First, here's a brief message from SK&F Co.
Your patients, their journey from fear, slow passage from a dark world of chaos to the ordered vision of reality. Your patient's progress is a tribute to your talent, your painstaking skill, and the benefit of modern psychotherapy.
Today, more than ever before, we feel it's important to remind you that when you wish to ensure the continuity of treatment so valuable to your special patients, it's up to you, the prescribing physician, to demand that the drug you prescribe is the drug they receive. To protect your patients, protect the integrity of your prescription. Always write Stelazine DAW, do not substitute, or use the format required by your state.
For almost 30 years, psychiatrists have relied on Stelazine in the familiar True Blue tablets to maintain their chronic schizophrenic patients through effective control of psychotic target symptoms.
And since, as you know, Stelazine apparently activates withdrawn, apathetic, or detached patients, you have a greater opportunity to reach your patient with other forms of therapy. Your patient suffers less, responds faster.
In addition, Stelazine offers these treatment benefits. Stelazine seldom causes excessive sedation. Stelazine demonstrates a low risk of anticholinergic effects and hypotension. Stelazine offers convenient, economical BID dosage.
And while Stelazine shares the increased risk of extrapyramidal symptoms associated with all high-potency neuroleptics, these symptoms, when encountered, are generally readily controlled.
We urge you to prescribe prompt, non-addictive, activating Stelazine for your chronic schizophrenic patients.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions such as pseudoparkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with Stelazine and or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing Stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions.
Be sure you're the doctor. Always write Stelazine DAW, dispense as written, or do not substitute. Or use the formula required by your state. Protect your patients. Exercise your right.
Now, here is Dr. Linehan on dialectical behavior therapy with borderlines.
Behaviorists, as most of you might be aware, have traditionally not been interested in personality disorders in the slightest, mainly because they didn't recognize the existence of personality disorders, and in fact, until very recently, actually didn't recognize the existence of personality. Now, there are three things that have really contributed to this changing quite dramatically just very recently. On the theory level, there's really been a shift in the theory towards a conception of personality that's based on the ideas of capability, whereas formerly the theoretical underpinning of behavior therapy was always a focus on performance. But once you move over to the notion of capability, then you get the idea that capabilities are necessary but not sufficient for behavior, and capabilities are a property of the person that goes across situations. Okay, so that's what's allowed behaviorists to start looking at personality disorders. And the next thing that's happened is an empirical advance. The empirical research into the covariation of the borderline characteristics and the development of a reliable method of measurement. And then there's the advance on the clinical front. What's happened, of course, is the behavior therapists, just like everybody else, started seeing the borderlines. They weren't writing about them, but they were actually seeing them in their therapy. Now, my theory itself developed from work with chronically parasuicidal clients. I think parasuicide is probably the term that's most commonly now used for suicide attempt and any other self-mutilative, self-injurious intentional self-injurious behavior. So I started working with this pair of suicides, and I've been doing that for about 13 years, both at a research level and a practice level. And so over these years, I started developing this kind of in my head typology. Not that I approved of that from being a behaviorist, but I still was doing it in my head. And I developed this treatment that went with this typology, a theoretical model. Really, the whole thing has been developed and based on the chronic parasuicide, who's also a borderline. And if you look at the conditional probabilities of being a borderline, if you've got parasuicidal behavior, it's over 0.8. It is very high. The people in my research are probably the most dysfunctional borderlines around. All the people in our project, with a few exceptions, are on SSI or public assistance because of psychiatric disability. They're all women. Most of them are not in significant relationships or not in a stable one. Many of them obviously can't work, and they have histories of sexual abuse. Some of them have been into criminal behavior. We have one who sets fires. We have 2 prostitutes, kind of off and on prostitutes. Some of them do a lot of stealing. Now, we haven't found alcoholism to the extent that anyone would be predicting, but certainly we've had our share of people with alcohol problems. So it's this severely dysfunctional group that the treatment has been developed on and really for. Now, I want to look at 3 areas theoretically. I want to deal a little bit with the dialectical philosophical approach because I think that that's what sets it off somewhat from ordinary more traditional behavior therapy. Then look at the etiology, then the resulting behavior patterns as syndromes, and then we'll just move into the strategies. The philosophical underpinning from the dialectical perspective is the notion that we all exist in an interdependent reality that's defined primarily by the dialectical tension between process and content, and that there's no absolute truth, but that all propositions contain within them their opposite. And then growth involves this constant process of synthesis, going from thesis to antithesis to synthesis, which then becomes the thesis, to discovering the antithesis, to moving to a new synthesis. Psychological disturbance, from this point of view, will always occur by adherence to one pole or the other of the dialectic. In fact, that's the definition of delusion. The adherence to one or the other pole. So therapy, then, can be thought of as 2 people, client and therapist. With a group, it'd be a group of people, attempting together to synthesize the dialectical tensions that emerge. Now, it's fraught with difficulty if the therapist ever rigidly holds to an extreme pole. And with a borderline, it's assumed that the client's always adhering to a rigid pole. It's rather like 2 people on a teeter-totter trying to get to the middle, but with neither one falling off. And then substitute for the teeter-totter a really thin pole balanced on a high wire. And you've got the client and the therapist trying to keep this thing in balance. I can predict if the therapist moves in this place on the pole, the client will move to that place. Now, I want to give you just an overview of the etiological system. What I believe happens is that the core problem is in the emotion system, and that the emotion system dysfunction leads to dysfunction in the self system, which in turn leads to a dysfunction in the interpersonal system. This is the opposite of your average psychoanalytic or psychodynamic theoretical approach, which would view usually the core problem is in the self system leading to an emotional disorder. I see the problem as a heritable or constitutional disorder in the emotion regulation system. The infant is born with what the researchers in this area would probably call a temperament disorder. It's a high sensitivity to signal stimuli. You can look at it as the low response threshold. The second problem is that within the emotion system, you have an inability to modulate negative stimuli. In other words, there's a heritable negative emotion tone which is likely related to the inability to modulate negative stimuli. And then the third part of the theory is that the child is born with a high emotional reactivity. That's really related to the sensitivity, high sensitivity to stimuli, but also high intensity. There's a fair amount of data that that's heritable. Just in my own theoretical point of view is the notion of the slow return to baseline. I had a borderline woman, and she has a lot of social anxiety. And if you know behaviorists, you know that behaviorists love systematic desensitization. So I decided to try that with her. With the ordinary person, part of that involves having the person imagine themselves in a situation. Now you only do it with the person who can both imagine and then experiences the accompanying high physiological arousal, emotional arousal. And then you do the treatment, at which point you say, okay, stop that scene, relax. Now your average person, you say, okay, stop that scene. They just stop it in their mind. And 20 seconds later, they're all relaxed. And you say, okay, let's try it again. And that's kind of the way the therapy goes. So I said to this woman, I said, okay, let's do this. She said she was kind of scared, but she said, okay. And she got it all. And then I said, okay, relax. Well, God, we couldn't get her relaxed. I had her outside, we were walking around, we were using every strategy I knew to get her emotional arousal back down. So I figured, well, it's just her. There's another technique that's also based on the same notion as systematic desensitization called flooding. And in flooding, you really pull out all the stops and you create enormous, intense emotion. And the notion here is people will get very aroused, but then it will eventually go down. My research associate was real good at it. So I said, let's try it. And he reported back to me that he had been there all afternoon, that he had gotten her up and he could not get her down. And I have no reason to believe he isn't really good. Now, a lot of people come in with this sort of temperament and seem to do okay in the world. In fact, if you have a goodness of fit between child and parent, where the parent fits the child's temperament, you're likely to do okay. So what I figure is, to get a borderline, you've got to first have the emotion regulation disorder, and then have a badness of fit in the environment. I call this the American Way syndrome, although I'm thinking changing it to the invalidating syndrome. This is the syndrome that really minimizes all difficulties, invalidates most problems, and suggests that anyone with proper motivation can do it, can make it, can be in control, and indeed can be happy. Happiness, or at least smiling in the face of adversity, is the American value. I think it's really typical of many families in the United States that our country especially has really glorified happiness as the essential value. Happiness meaning positive feelings to the exclusion of any negative feelings. There's only a slight problem, which is that it does not work with this population. You've got the child who is in a family preaching this particular point of view who cannot do it. The worst situation is the child who not only came out of an invalidating family, but married into one. Okay. The woman who's married to the husband who's verbal, logical, and rational, and who believes that all problems can be solved if you just think straight and change your attitude. The essential core of it is that it minimizes and invalidates. It's not a family that says, let me understand you and validate you as you are. The repercussion of this is that the child gets no regulation training. Let's see what we can do to help you learn some skills to cope with the problem. It's dealt with as you don't have a problem, you're just not motivated, you're not trying hard. If you scratch a borderline, they'll tell you they're not trying hard, because of course the borderline completely adopts this American Way syndrome themselves, while at the same time completely rejecting it. The child starts saying, I can, I will. But then they have this inevitable failure, and then the shame that goes with that, and then the suicidal behavior that comes from, there's a fatal flaw. I mean, there's something wrong with me. I mean, if I was okay, I could do this that they want me to do, and since I can't, I don't deserve to live. I'll kill myself, and you get a lot of this in a lot of borderlines. But then you can flip over to an occasional kind of insight into, hey, there's something wrong here. I can't do this. They're wrong. At which point there's enormous rage, especially in the face of I can't and them saying, oh yes you can, you just won't admit it. At which point you get into the I'll show you I can't rage, and again into suicidal behavior. When I say suicidal behavior, it could as easily be alcohol addiction, drugs, or almost any other dysfunctional behavior that can serve a communication purpose. Okay, I'll use suicidal behavior because that's what I work with. So the dialectical tension that gets set up right at the beginning is the tension between no emotional control in the presence of apparent total control. Think about the hyperactive child in the family that says, just sit down and keep still, versus the family that says, you're hyperactive, let's figure out strategies and let's deal with how you're going to interact in school and get through, etc. The hyperactive child with the goodness of fit family does reasonably okay as adults, and the hyperactive child with the badness of fit family, poorness of fit's a better word instead of bad, has lots of trouble in adulthood. Now, moving into this, since there's no training, you've got a child who's got enormous emotion lability. Their emotions go up and down. What happens then is you have the lability and a real intolerance for emotion, mainly because of the absence of control. So you've got this exquisite sensitivity, extreme stimulation and response, and very little control. Which leads to an intolerance for the emotion itself. One of the coping methods, denial or an inhibition of emotion. The word the clients can really relate to much better is blocking. I'm not positive what the phenomenon of blocking is, but borderlines understand it if you talk about it. They even know what they're doing, but they can't articulate it too well either. In other words, the child does not learn how to tolerate negative feelings, and so they block or don't go through that process of grief of the inevitable losses that everyone suffers. I mean, part of development from birth to death is a series of negotiating losses for all of us. And the ability to negotiate this and grieve, integrating the loss, is essential. And what I find in adults is what I call now the blocked grief syndrome, where usually I discover that you can find a lot of things out of their past that they really haven't gone through. Now, part of therapy then is going to be helping the person go through the grief process for those key events. Sometimes the key events that they have to grieve is the loss, or really the non-existence, but the loss of ever having a warm and nurturing family. That's why I think you have in the history of borderlines, if you look at them in terms of percentages, you have an enormous amount of extreme abuse in childhood. Think for a moment. Sexual abuse is almost the epitome of invalidation. The person who's sexually abusing the child always tells the child that they love them, that this is good, that they'll enjoy this, mainly because of their own delusional system and their own needs. But the child's perception of this as something's wrong here is rarely validated in the abusive family. You discover that that's one of the primary components of the whole thing, was this massive invalidation of their own experience of what was going on. If you're blocking, you're beginning to block the core part of your experiencing of yourself. And I think that that's the core part of the emptiness experience that is so characteristic of the borderline. What are your options? You don't have too many of them. You haven't learned how to regulate any of this, so the person escapes into drugs, alcohol, suicidal behavior, sex, etc., which I view all of these impulsive type behaviors as essentially escape behaviors. Or another way to think about it is problem-solving behaviors, inadequate problem-solving behaviors. Now, this disorder in the self-system leads to disorders in the interpersonal system. We have first what I call the apparently competent person syndrome. This has been one of my most useful ones to helping me understand what happens. It turns out the clients usually can resonate with this just immediately when you describe it to them. One of my strategies in my treatment, which I call the professor strategy, is the strategy where we teach the clients a theoretical system to understand their own disorder. We don't particularly push it as truth. That would be real problematic from a dialectical perspective. But we do push it as a point of view that one could use for self-understanding. Remember that woman I was telling you about I did the systematic desensitization with? She's a teacher and she had problems at school. My colleague, John Childs, helped me develop this. When we were trying to get her to role play how to cope with this, well, when we were developing the treatment, I couldn't imagine how she would not have social skills. She just seemed real competent to me. So I really wasn't too good with her. I invalidated her. She kept telling me she couldn't do it, and I kept thinking, boy, you sure seem like you can to me. And I would kind of push her, thinking that the problem was a motivational problem. She just kept failing miserably, and I kept saying, oh, come on, you can do it. And finally I said, out of desperation, I said, listen, you want me to show you how to do it? John and I role-played this, and she was just aghast. She said, I never thought of that. It became quite clear at her reaction that the idea of handling it the way we handled it had simply never occurred to her. And now I find, especially in my group skill training, that in fact, if you come out of a family that invalidates problems, that you don't really learn how to solve interpersonal problems. And I'm amazed at our skill training at the fact that these women will look at this stuff and they've never even thought of it. Stuff that I consider rudimentary. They appear very competent. This is one of the tragedies of this group, because you tend to react to them as if they're very competent, just like I did with my client. And the world reacts to them the same way. Everybody thinks they're really together, when in fact, of course, they're not. So they don't present themselves as needing very much validation, support, or understanding, or help. And indeed, they don't get it, which just keeps exacerbating the problem. Borderlines, I think, tend, especially the severely dysfunctional, to have multiple crises, many of them very real. Many of the borderlines I work with come out of actually middle-class families, but they don't come out of families rich enough to pay for a lot of private therapy. Most of our people have used up their insurance. And now they get poor and their families can't provide a lot of help because they need such massive help. So if you have a true crisis life and no skills, then crises become worse crises. And then we have the syndrome that comes out of the lability and the identity diffusion, which is the learned helplessness phenomena. If you grow up in an invalidating family or currently live in one, what really happens is you have to yell loud to get anything. It's probably possible to develop borderline syndrome at an older age. A woman who would have been okay could end up pretty not okay if she got into an invalidating marriage. But you get into this relationship where you aren't listened to, and what do? You learn to scream for help, and that's exactly what borderlines do a lot of the time. The dialectic here is the learned helplessness phenomena in the face of the apparently competent woman phenomena. Because of course, in the family of origin, and in our culture, what was valued was competence. So the person that can put on the veneer of competence is going to do it. So there's the tension of, I am competent, I can do it, with I can't do it, I'm completely incompetent. But the central core dialectic of therapy, all therapy I think, is the dialectic that change occurs in the context of acceptance of what is. And I see that as the core dialectic that we struggle with, especially with borderlines, constantly throughout the entire treatment experience. Now, what makes therapy behavior therapy? Okay, one, it's the focus on capability enhancement. The notion here is that dysfunctional or emotional illness or psychopathology, whatever terms you want to use for this, can be thought of as lacking requisite capabilities, and therefore therapy itself is viewed as increasing patient capabilities, client capabilities. The underlying assumption is the assumption that the individual has the capacity to develop the requisite capabilities for a meaningful and satisfying life. I say, now look, the idea here is not to get you to tolerate this awful life. I agree with you, this is the pits. But the idea here is to get a life that you want to live, not learn how to live a life you don't want to live. The second is the notion of problem solving. The third thing that you always find in behavior therapy is contingency clarification, trying to always keep very clear what the contingencies are. So everybody knows what will happen if they pair suicide, or if they don't show up, or if they do this or they do that. But we're also very clear about trying to help articulate the actual contingencies that are occurring in the real world. In other words, what are the outcomes? Helping the person become a good observer is another way to think about it. Your behavior will conform better to the real world if you're aware of actually what the contingencies are. The fourth thing that we do that's behavioral is what I call escape management. It's setting up contingencies for escape behaviors to try to keep them under control. Obviously, the main one we're trying to control is suicide. I think Mintz once said that all psychotherapy with a dead patient is unsuccessful. Especially in suicidal behavior, one of our primary escape management techniques is to try to hammer constantly at the real outcomes of suicidal behavior. So we do escape management and then focus on the observable present. This doesn't mean that we don't talk about the past, but we tend to tell people that the past is simply the present in terms of long-term memory. Let's move then to what the targets are. The focus on a dialectical synthesis comes out of the dialectical focus on the treatment. And what we actually move towards is the ability to think dialectically, to be comfortable with paradox and comfortable with ambiguity. The dialectical strategy never involves trying to get rid of paradox and ambiguity, because we have this assumption that the person can begin to integrate that themselves. Now, the next thing that we deal with is affect regulation. Obviously, you can imagine that this would be a key focus of our treatment, since we view affect dysregulation as a key problem. We're trying to deal with increasing the ability to experience emotions and also the ability to modulate emotions. And you discover very quickly, if you do treatment with these people and you're at one end, or they will be at the other. Typically they'll say, if you try to talk to them about modulating or controlling, you mean you're against having emotions? Why? Don't you want people to be emotional? And then you have to work towards a synthesis of how you both want to be able to experience but modulate. The next thing is interpersonal effectiveness. Because of this apparently competent woman veneer plus the family situation, you have a person who often does not develop the ability to deal with interpersonal conflict adequately or effectively. And there are two problems that come up. One is the inability to ask for help. That was punished. That was not reinforced in the family setting. And that leads to suicidal behavior. You're in a crisis, so you can get help by getting suicidal. And the other is the inability to ask for help leads to identity problems. I came onto this back in my early years. I was known as a assertion person. But it got kind of frustrating because we talked forever, it seemed to me, and we still didn't know what they wanted. So I said, listen, let's quit that for a while and let's figure out what are the possible things you could do. If you wanted this, what would you have to do behaviorally to get it? Well, I'll teach you those skills. You don't want this? You want to say no? I'll teach you the skills of saying no. It's like a little miracle. I would teach people how to figure, let's first get the skills, then we'll figure out what you want. I discovered we never had to figure out what they wanted. If we got them the skills in the first place, people just seem to get clear. And I've carried that over into our program, and we focus a lot more on skill training interpersonally than trying to figure out what they want. The next thing is to focus on distress tolerance. What I believe is that the inability to tolerate pain completely limits your ability to solve painful situations. One of the things that all people have to learn developmentally is delay of gratification. And you have to have the appropriate learning environment to learn it. Your average borderline has learned that the way to control behavior is through punishment. Just watch them sometimes. They use punishment at the drop of a hat. And they really believe that punishment works. They don't have any idea that it's probably the most ineffective way there is to go about controlling behavior. They're afraid to give up punishment because they don't have anything else. And we do a lot of focusing on the idea that punishment does not work. Our key theoretical strategy is we first deal with suicidal behavior. And if they're doing it, we're talking about it. And as soon as that's gone, then we focus on the next behavior that's interfering with everything. If they have some other addictive behaviors that are really making therapy impossible, we focus on those. We focus on it to such an extent that we have one of my clients quit overdosing. She said, I had to quit it so I could talk about something else in this therapy. And I said, you're so right. Borderlines perish suicide obviously a lot more than they kill themselves. But you're a fool, in my opinion, if you start thinking that they're not going to kill themselves. That's why I'm so against the notion, the terminology of suicide gesture and manipulative suicide attempt, which are current in some circles. I find it very distressing. It's even in DSM-3, this notion of manipulative, which is the most pejorative. I've never heard that word used in anything but a pejorative framework. My own opinion is the chances of them ending up dead are a lot greater if you start using terms like gesture and manipulation, because that puts you at one end of the pole, and they're just as likely to go to the other end to get some balance here and show that in fact is not the case, that they indeed very serious. And as you can see, in my whole treatment is just really a list of strategies. Basically, dialectical behavior therapy is defined in large part by these strategies and also by the targets and the focus. The hospital strategy is probably where we're most different. Our control group spending enormous amounts of time in the hospital, and our people aren't. We don't believe in hospitals very much. And if we get them in, we get them out right away, as fast as we can. And we don't get them in there very easily. And then our medication policy, I won't even see a suicidal person, except for a very brief time, who's on any drugs that could be lethal if they saved them up and took them. And they either get it injected or they don't get it.
This concludes Part 1 of Dr. Linehan's presentation. Please turn the cassette over to hear Part 2 of Dr. Linehan's presentation on Dialectical Behavior Therapy with Borderlines. This program will continue in a moment with the second part of Dr. Linehan's discussion of Dialectical Behavior Therapy with Borderlines. First, here is a message from SK&F Co.
The fragile shell of the borderline patient. Like the shell of an egg, it may be seamless, secure.
Your borderline patients may manage a career, family relationships, rewarding friendships, until the pressure builds. Pressure to the point of overwhelming stress.
Then the fragile shell may crack. Psychotic symptoms emerge.
You can help return your borderline patients to reality by controlling emerging psychotic symptoms with the short-term use of non-addictive stelazine, brand of trifluoroperazine hydrochloride. And because stelazine seldom causes excessive sedation, your patients will remain more alert to other forms of therapy. Stelazine offers a convenient, economical BID dosage regimen that helps ensure compliance.
When the fragile shell of the borderline patient cracks, remember, stelazine controls occasional psychotic symptoms.
Stelazine is contraindicated in comatose or greatly depressed states due to CNS depressants, in cases of existing blood dyscrasias, bone marrow depression, and pre-existing liver damage. Avoid using in patients hypersensitive to phenothiazines. Physicians should be alert for neuromuscular reactions, such as pseudo-Parkinsonism, tardive dyskinesia, and other adverse effects associated with phenothiazine therapy. Patients with a history of long-term therapy with stelazine and/or other neuroleptics should be evaluated periodically to decide whether the maintenance dosage could be lowered or drug therapy discontinued. Before prescribing stelazine, please consult the accompanying booklet for complete product information, including additional warnings, precautions, and adverse reactions.
Be sure you're the doctor. Always write stelazine DAW, dispense as written, or do not substitute. Or use the formula required by your state. Protect your patients. Exercise your right.
And now, Dr. Linehan.
The overriding strategies of the dialectical focusing, we've talked about that. I personally find that the most difficult thing to manage in doing the therapy. And it's such a process rather than a content that it requires constant attention to the relationship, because it's really based a lot on the relationship, and it's that moment-to-moment watching. Now, the next strategies are ones we use a lot. The first one is the basic validating strategies. What we're trying to do is provide an environment that provides some validation for them as they are, to allow them to look at themselves as they are and learn some self-confidence in themselves. And the key strategy is, and it takes the dialectical skills here, is always to look for the kernel of truth in what they're viewing or experiencing or seeing. Now, there are two components to validating. The first involves the communication of empathy. In other words, I see how you feel. I could feel that too. And the second part of it is the communicating that, and in the context of reality, your emotions make sense. Now, this is based on a fundamental assumption that everything makes sense if we only understood it all. That essentially there are no ununderstandable or uncaused emotions, behaviors, or cognitions. One of our strategies is to use storytelling. I'll tell you this little story. I don't know why the story works well, but I must tell you this story works really well. Everybody gets it. And this is how it is that everything is understandable and everything is caused. And how it is that we can sometimes not see that. And so you just have to imagine that you're in your car and you're driving by this factory. It has all these windows, got this big door. You see all these boxes are coming out this door, they're just coming out, and you're sitting in the car thinking, my God, what are all those boxes doing coming out the door? It seems sort of silly nobody's there to get the boxes. And then I could say to them, what do you assume is going on? You always assume that there is a cause for those boxes. You figure something's going on in that building making those boxes come out. And they always get it right away because, then you can take the box and the building and apply that to them. And the box is their thoughts or their feelings or their behavior. Now, you can then use this one again when you're trying to teach self-management skills and how willpower and punishment don't work. Willpower would be the strategy of you're driving down and you see all this happening and you think, oh, this is terrible, we don't want those boxes. You start yelling from your car, stop boxes, stop boxes. And of course the boxes never stop. Because yelling and willpower and telling yourself to be different don't make you different. The next strategies are the basic relationship strategies. The fundamental point of view that I have about therapy is that the therapy relationship is an important relationship in its own right. And it has to be worked on just like any relationship has to be worked on. And that you work on it not because the client's got some sort of pathology, but because this is, in fact, a human relationship. The third basic strategy is the problem-solving strategy. The first step in all problem-solving is always the behavioral analysis. And the behavioral analysis is different from insight in the sense that it's always focused on the specific situation that we're talking about. And what are the events that led up to it, and what were the consequences? It's amazing how people don't sometimes pay attention to exactly what was going on in the environment. Who was doing what? And then you look at what were you doing? It could be that what they're responding to is their own behavior. It could be that they're responding to their affect. They're escaping, for instance, from pain, which a lot of what goes on. And then we look at their cognitive patterns. What are their assumptions and beliefs that might be influencing what happens? What are their expectations? Once you have a fair grasp of what they're responding to, sort of what's leading up to it, then you start trying to figure out how could you change it. Then we have capability enhancement, skill training. Skill acquisition is when you're actually trying to teach them a new skill. And the main methods of skill acquisition are modeling and instruction. And then there's contingency management. This is where you control contingencies and you collaborate with them and getting them to control contingencies. You try to respond to their behavior in such a way that it encourages more appropriate behavior. And I'll give you an example of this with one of my clients. At the beginning, I used to get phone calls from her. She was an alcoholic, borderline. God only knows how many overdoses and slit wrists and hospitalizations she'd had. Lots of them. She's married in the original Amway family. She would call me up drunk in the middle of taking an overdose, hysterical, saying therapy was over, she was dying, and this was the end. Now, we have a little rule we tell them about in the beginning. Don't call us after you've overdosed or cut yourself because you've solved the problem. You don't need us anymore. Go to the hospital, do something, but don't call us. So right at the beginning, we had to be clear, I don't talk to you when you call up after you've already taken drugs. So she quit calling me after she took drugs, and now she calls me and then takes the drugs on the phone. there's a skill to this of figuring out just when you can push them a little further. And I finally said to her after a couple months of this, I said, listen, I don't want you calling me anymore and taking overdoses while you're on the phone. And we talked about the effect it was having on our ability to work together. She didn't call me up and take pills, but she would call up drunk, threatening to take pills. So with that went on for a few months too. And I finally said, I've decided I'm not talking to you anymore if you call me when you drink. Now, the facts were she couldn't talk to me unless she drank. So first we had to go through a couple of months of scheduled phone calls where she had to call me on certain times, and we had to practice getting her so she could actually call me, because she wouldn't call. She felt that this was just not something she was capable of. She said, how does this, and I said, how are you drinking? And if she said yes, I'd just hang up the phone. I'd say, I'm sorry, I don't talk to you when you're drinking, call me back tomorrow, and I'd hang up. Fortunately for us, she didn't lie. If clients lying, then we don't deal with anything else but lying. And I started saying, surely you're able to call me up and talk about a problem without threatening to kill yourself. She said, you're right, I am past that. At which point I started saying, how is it you always have to be in a crisis to call me up? And she said, well, I see your point. And now she calls me up and says, I'm having trouble dealing with this. I can't seem to figure this out. Let's talk about it. And then we talk. And now we're mostly dealing with the shame and humiliation that's involved in her calling me up when she's given up alcohol, suicide attempts, crises, suicide threats, and getting hysterical to call me. And this has taken the whole 5 years. The next strategy is contingency clarification, reality testing. This is just giving information. I tell them everything I know. All my theories about borderlines, much as I hate the word, I've discovered it just simplifies life to say, look, that's your diagnosis now. Here's the research on it. We give them, in a sense, also a lot of theories to try to help them explain themselves, like the notion of the problematic fit, the non-goodness of fit. We give them a lot of information about a behavioral perspective on suicidal behavior and how that might be related to their problems, etc. We also give them information about what behaviors are appropriate in therapy. Often they don't know what they're supposed to do in therapy. I think we sometimes make the mistake of assuming since we know, they must know. And then if they're not doing it, they're just not doing it because they're, resisting or something or other. Okay? When in reality, sometimes they just don't know. For crisis intervention, when a client's in a high state of crisis, generally, you've always got to validate the affect. That's got to be first. Okay? Because you can't imagine how calming it is. If you don't let them know that you understand what's going on with them, then the whole thing can dissolve into them trying to get you to understand. So you've got to get past that. Then you have to move into short-term problem solving. This is how you're going to survive the next hour. I just don't think anybody has any business at all working with these people that doesn't have a colleague that they can talk to. That could be your own personal therapist. I think being in therapy is not a bad idea if you deal with many of these people, because it helps you keep things sorted out yourself. And I've discovered for myself that it's essential that I have a few what I now call normal clients. Real people who come in who actually say they're getting better. I think you need a few of those, because otherwise you'll start thinking you're a really bad therapist. I certainly don't think everybody should work with these people. And there are a lot of clients I don't work with, and there's a lot of commitment involved. I think that you make the commitment that you're going to interact with them and be a caring person in their life with the responsibilities that are involved in that. I've surely gotten as much from my clients as I've ever given to them.
This concludes Part 2 of Dr. Linehan's presentation. The program now continues with a discussion of integrated treatment of borderline and narcissistic disorders from a family therapy perspective by Stephen Jones, Marion E. Kenworthy Professor at the Carl Menninger School of Psychiatry and Mental Health Sciences. Now here's Mr. Jones.
Let me first talk about the treatment of severely disturbed families, which certainly includes patients with borderline and narcissistic characteristics, and look at some of those characteristics first. Now, there are particular dysfunctional family styles that have been sorted out as predictable patterns, and Mnuchin has described some of these as enmeshment, overprotectiveness, rigidity, and lack of conflict resolution. Lyman Wynn, in turn, has directed attention to characteristics of highly disturbed families, such as fusion versus differentiation, homeostatic balance, proper distancing in relatedness, resistance to disequilibrium related to growth and change, and what he calls the rubber band concept for protection and stability, so as to shut out or extrude strangers. Dysfunctional family systems have a high degree of connectedness and togetherness. They have covert coalitions which cross generational boundaries. The closeness and distance between family members is determined by the covert coalitions, regardless of what they say, which is usually messages that are incongruent. And there are third-party triangulations which frequently deflect the conflict and closeness between pairs. Let me make some comments now about assessment and diagnostic issues as one begins to work with these kinds of families. As one begins to examine the family dance, it's important to be mindful of the repetitive triangulations inherent in these systems which serve to distract, deflect, and protect family members from perceived fears and potential losses, as well as preventing therapeutic interventions, because they'll invest a great deal of energy in maintaining sameness. The more highly dysfunctional a family system, the more rigid, complex, and puzzling it will be. The treatment of these families is always a major challenge. They are never easy. The unspoken contract from the beginning is, please help us feel better as long as we don't have to change. For various reasons, these families, especially during developmental transitions, have great difficulty tolerating growth and change, and at the same time, they maintain the sense of the stability that they feel is their safety net. As a result, the therapist will experience polar shifts from extreme rigidity to explosive crises with the slightest shift in the family structure or rules. This is especially predictable when the patient attempts some degree of emotional separation, frequently observable as young adults begin venturing out of the home. An assessment of many hospital young adults shows that the core of resistance to change is grave anxiety and panic that any movement towards autonomy and independence will shatter the family unit and cause the parents to hurt one another, divorce, or abandon the patient forever, thus throwing him or her completely on one's own fragile resources. Now, the underlying issue, from my point of view, always is separation to some degree or another, and the fear of that, and the risk and the perceived injury that might come to the system. Now, in responding to these families' requests for help, let me list a number of concepts and strategies that I work with that I feel are very, very important. First of all, one needs to understand the dilemma regarding change and what the family is facing. They're terribly important in terms of my assessment of highly dysfunctional families. It requires accurate data about the concurrent developmental crises. One carefully has to listen to metaphorical themes and attempt to discover the natural paradoxical binds which exist in the family. Second, it's important to join the family's resistance. Many of you may know what I mean by joining the resistance and moving with it, going with it, rather than confronting the system or trying to go in what I would call a straight way. It's more moving in somewhat by degree of a paradoxical stance, but it's moving with resistance and dealing with them that way. Particularly because most of these families, by the time they get to you, if you're a well-established treatment center, they've had 1, 2, 3, 4 treatment failures. And they're well rigidified in knowing what other people have tried to do in terms of making interventions. The third point is the therapist needs to clearly understand the family member's perceptions of the problem. As the data centralizes around central themes, it will begin to give clues as to the functional purpose of the disturbed behavior. From my point of view, dysfunctional behavior always has major functions in the system. And usually it has to do with maintaining sameness, trying to stop change, and to prevent further growth. the patient will begin to sacrifice themselves for the system to try to put their growth on hold, and they pay a higher and higher and higher price. Now, as you pursue data in understanding the function of the behavior, you'll begin to understand better the primary triangle, which will be the dysfunctional triangle, usually of patient and parents, and then you might hopefully begin to gain a better understanding of the self-sacrificing position of the patient and his loyalty to protecting the family or specific individuals in the system. As one begins to understand the function of the patient's behavior, hopefully one can begin to frame in a positive way, through positive connotation, regarding the behavior of the patient, so that you can make some statement to the family that might hopefully shift their perception of the situation. Although dysfunctional behavior always contains both negative and positive meanings, it is important to focus on the positive intent inherent in family members' behaviors from one another. This keeps resistance more manageable and hopefully can surface new options for change. With these beginning interventions, the therapist must listen closely to the feedback data, realizing that the initial interventions usually are the easiest. If one comes close to stirring movement in the family or arousing anxiety, the system will frequently and immediately, usually, counter-move towards stabilization to lead the therapist away from the original strategy for change. Now, those families are absolute masters at counter-move to reestablish sameness because they're scared to death of change. They might agree with you verbally. Behaviorally, you'll sense in time that they really are disagreeing. Many families will disagree with you immediately, and you'll find behaviorally that essentially they are agreeing with you and moving towards change. And there are some families who adamantly will disagree with you, and the behavior in a congruent way confirms that they definitely are disagreeing. It's very complex to figure out when you make interventions where you're going with these families, because they'll confuse you. You watch for congruency between what they say and what they do. Congruency may not be a foolproof method. We followed a family with Art Mandelbaum, a group of us, for a while. The family always disagreed with everything Art said and everything the group fed in by live supervision. And came back, and when we would ask about the assignment, continued to disagree and say that we were not helpful and were not relevant to their problem. Except every session, things improved with the child. The last day of termination, they were still complaining how we were way out, not relevant, and things were much, much better. They maintained that stance all the way through the treatment, never changed it, but we had steady improvement in terms of behavior. Okay? So some of them are more difficult than others. Remember, of course, as you work with these kinds of families, to be mindful of the impact and complication which it has upon you, the therapist. It takes but a few brief moments to feel the complexity and the overwhelming nature of these families in an interview. If the families are particularly rigid, psychotic, or schizophrenic in nature, you will rapidly sense the morass of data flooding upon you, which can appear meaningless and confusing. And when you leave the session, you'll feel like the crazy one, and they'll be going away acting sane. It only takes about 5 minutes in an interview with a very highly disturbed, skillful family to make you very, very confused and very, very incompetent. Now, some therapists state that you really cannot do the family work alone, that it's necessary to have help, co-therapists, live supervision, whatever, to help you keep dealing with the powerful impact of these kinds of systems. Now, if these traits from these families are accompanied also by chaos, frequent crises, few emotional boundaries, you can feel very quickly to be very incompetent. Under these circumstances, it is relatively easy to have negative reactions to certain individuals in the family, to particular relationships, or to the family as an entity. like how wonderful it is when they cancel their hour and don't show up. You hope for that on a more frequent basis. Common feelings of the therapist are discomfort, defensiveness, and being excessively anxious. Now also be mindful if you've got staff who are somewhat new to the field and they're working in inpatient units or even outpatient and they have a number of cases of these kind, you better be very, very helpful to them in supervision because they'll render them helpless very quickly. Now, as the experience progresses, the therapist can become blocked, bewildered, you can experience loss of control, or just kind of be swallowed up. They're the kind of families that might rigidly, on some occasions, absolutely keep you locked out in an interview. They won't tell you anything. They won't allow you to enter. They won't allow you to join them. The next interview you come in and they'll just suck you right in and swallow you up before you even know what's happened. Now, it's very, very hard to keep your balance of how to get in far enough but not get engulfed so much that they disarm you and you lose all of your impact and effectiveness. Thinking of these characteristics brought back to mind an observed family interview that I had a few years ago with a well-experienced master therapist in New York. The presenting problem was a very seriously disturbed, psychotic young adult who was crisis-prone, very resistive, and explosive. And the therapist was doing the demonstration of the interview for us as a training group. So we had paid money and tuition to watch her operate. And so she had pressure to produce. In the first 5 minutes of the interview, as she made attempts to join the family, she was quickly defeated by the patient objecting to her questions, jumped up, ran out of the interview, and into the New York subway. The family went into immediate disagreement, confusion, with considerable crises, and then the entire family went running out of the office into the subway to find her. And needless to say, we had a therapist sitting there abandoned, alone in her office, contemplating what had happened. Now this was a very, very masterful, skilled therapist. Needless to say, she was embarrassed, and as we re-looked at the 5 minutes of the interview, you could tell the moves that did not work. And of course you can always try to do Monday morning quarterbacking, see if you could have done differently. But there were powerful agendas that were operating. Now, in the treatment with these families, as progress becomes restricted, or in many situations where the treatment is blocked, the therapist can experience a feeling of being completely paralyzed, or on the opposite end becomes mobilized to work harder and harder, taking responsibility for change, and that he's going to fix them. Now, to assist therapists with some of these difficulties, it's important for therapy to be guided by the following concepts. First one is to maintain a non-judgmental attitude, try to stay in some position of neutrality, and leave the responsibility for change with the family. We get into too much business of rescuing. Now, this position will also assist the therapist to avoid his own agenda for change. Frequently, our own therapeutic goals also are much higher than those of the family. Hence, their motivation for treatment and their own goals must be respected. A negative reaction to individuals or the entire family can easily occur. Therefore, it's important to carefully monitor your own negative reactions or your own countertransference. It's more beneficial to intervene gently, slowly, and cautiously. Careful judgment must be used regarding the timing when issues are addressed and the way special relationships are shifted and when major interventions are attempted. Frequently, therapists become overambitious regarding the speed of the interventions and the amount of change they attempt to achieve. Possibly the most challenging concept to develop is the therapeutic ability to understand the game or the family dance or tracking the sequences of behavior in which these families are engaged as a system. And every one of them has their own dance and their own meaning in terms of how they're trying to deal with one another. I cannot emphasize strongly enough, especially in hospital treatment, for a patient to be able to use the treatment and improve, The family dilemma regarding change must be understood so the patient can be freed from the dysfunctional triangle which keeps them bound and prevents individual growth towards separation and autonomy. The patient must be given permission to take care of self rather than sacrificing personal growth to care for the family. And that's a very, very key, crucial issue for me in terms of the treatment of these families.
This concludes the second in a three-part series on borderline and narcissistic disorders, recorded live and on location at the 8th Annual Winter Psychiatry Conference of the Menninger Foundation. SmithKline & French Laboratories sincerely appreciates the cooperation of the Menninger Foundation in the production of this continuing medical education program. The views expressed here are those of the individual speakers. Their participation is not intended as an endorsement of SK&F products. It should not be inferred nor assumed that the participants are expressing the views of SmithKline & French Laboratories or any other manufacturer of pharmaceuticals. This program was produced by SmithKline & French Laboratories.